Hello, fellow foodies, and welcome back. This is Dr. Cassandra Quave, and you're listening to Foodie Pharmacology, the science podcast for the food curious. This week on the show, I'm going to be speaking with one of my colleagues and friends, Dr. Ted Johnson. Ted is internationally renowned for his expertise in understanding why older adults have to wake up from sleep at night to urinate. So, if you've ever run into problems with that, which I think many of us do as we age, he's the guy. And so let me tell you a little bit about him before we dive into the questions. Dr. Johnson graduated from Northwestern University Medical School and from the UNC Chapel Hill School of Public Health. He is the chief of Emory General Internal Medicine and the chair of Family and Preventive Medicine. He's also a clinical investigator at the Atlanta Veterans Administration healthcare system. Ted works in geriatric medicine, so that's the treatment of older people. And his specialty is really dedicated exclusively to providing high quality, patient centered care in older adults. He's been in clinical practice over the past 25 years. He's got lots of experience working with this population and especially in helping patients manage bladder problems. Um, and overall, his research and clinical work is really focused on helping older adults to more fully participate in life and community and kind of get these things under control. So it's great to see you, Ted. Thanks so much for coming on the show.
Thanks, Cassie. I'm really excited to be on the show today. It's such a pleasure to work with you. You and I are both here at Emory University, and so I get to hear about your work before I get to meet you. But either way, it would have been an equal pleasure to either meet you first and then know about your work, or know about your work and then meet you. And so you've been so kind in some of the initiatives that we've done, and it's really a pleasure to get here and talk with you because I think that I'm interested to know what you think about what I think about what patients think. And so, well, I think
Awesome.
over the course of our time, we'll get there together. Thanks.
That's amazing. Well, why don't we start with some basics?
Sure.
I'm guessing that some members of our audience may not fully understand what the definition of overactive bladder is, and kind of
Right.
maybe you can give us a little bit of background on like what does this entail? What are the symptoms like? And when we say older patients, are we talking in our 50s, or is this something that more that happens when you're like 70s or 80s? Kind of what's the patient cohort look like, and what are those symptoms like?
Yeah. So overactive bladder is a really interesting topic, and I've been watching this space for about the past 25 years or so. And so, um, previously in bladder control problems, you basically had to insert catheters into people's bladder and run pressure sensors to understand what was going on. And at some point in time, people are like, well, why don't we start with the patient story and talk about what symptoms they have? And so, overactive bladder is really one of those first attempts in the scientific literature around bladder control to talk about what do the patients have. And so, overactive bladder can be something that men have, something that women have, something that folks in their 40s have, something that folks in their 80s more likely have. And so here's the definition. So it's always good to start with the definition. So it is urgency, urinary frequency,
Mhm.
nocturia, or peeing at night. And you could either have or not have urge related urinary incontinence. And so it's always troublesome when a definition of a term has a term that's not defined. And so,
Subdefinitions. Yeah.
yeah, urgency. If you wanted to talk about what urgency is, most people would understand what that is because they're like, I have an urge to go to the bathroom. But so
Mhm.
it is a difficult to suppress feeling of a need to get immediately to the bathroom with difficulty holding. So that's urgency, and so urgency is the main symptom in overactive bladder.
And so for anyone listening that's ever had, like, let's say a UTI, which I'm one of
Right.
the many people that have had a UTI before, you is that the same kind of feeling of urgency that, like, because you have to urinate frequently when you have a UTI, or is this a little bit different? Because I know that's microbial, you have microbial involvement there, but
Yeah, it's the same sensation, but it's excluded from the definition of overactive bladder. If you have a urinary tract infection, then you don't have overactive bladder until the urinary tract infection is treated, and then you might have overactive bladder not related to the infection, but you might have it on your own. And so this is in the absence of an infection that someone would have
okay,
overactive bladder.
great. And then I have another question. I've heard about, kind of enlarged prostate, like benign prostatic dysplasia, where you can have difficulty basically evacuating the urine fully among men. Is this also distinct from that, or is it kind of in the same group of things?
It's beautiful that they're overlapping in a confusing way. So
Okay.
that's the employment act that we have here in medicine, is that things are confusing sometimes. So 7 symptoms in prostate problems. 4 of them are kind of like, I have trouble pushing out my urine. I have trouble that my urine stops and starts. I have trouble in that my urine stream is weak and it doesn't feel like my bladder's empty. So those are 4 of the 7. And so those 3 remaining ones actually overlap precisely with the overactive bladder, meaning urgency, frequency, and nocturia.
Okay.
So men and women have this both, probably from different causes, because women don't have prostates.
Yeah, that makes sense. Okay, so for all of our listeners, you may be wondering, why are we listening to a discussion about overactive bladder? It's a food podcast. We're getting there. Don't worry. Hang in there. Um, so let's talk first about classic treatment paradigms, and then I'm gonna get into the food aspect. I'm just giving them a little
Okay.
teaser. Okay.
Yes. If you were hoping to turn in to find out how I was attacked by a bear near the river, that's not this podcast. And so we're going to get there. I promise we'll get there. I read the brochure. I watched episodes. I know what we're talking about. We're going to get there.
Well,
Okay. So you go ahead. You ask me some questions about
yeah.
overactive
Well,
bladder.
and
We'll get to the point.
for those of you that haven't heard the bear story, definitely tune into Sue Aiken's episode on the show. It's incredible. She's incredible.
Yes. Yes.
Okay. So we're talking about this sense of urgency of overactive bladder. So as a physician, what are your options? Like what's in your toolkit to treat somebody
Right.
with this? Like what's the standard of
Right.
care?
Yeah, this is great because this actually sections out kind of what I do and why I'm interested in the food question
Mhm.
and what's commonly done. So, overactive bladder is commonly treated with behavior and exercise first, and that's kind
Mm.
of my go-to. And so, by exercise, I'm talking about what people understand as Kegel exercises,
Okay.
and surprisingly, I'm talking about that in both men and women. Both in our research and clinical trials, we've done Kegel exercises with men, and I'll explain why we do that. And then the other thing to say is that then you talk about, all right, so maybe you're drinking too many fluids, or maybe you're drinking fluids with caffeine, or maybe it's the timing of your fluids and those sort of things. And so those are kind of the behavior and exercise things that you take first. And a lot of the times, some of these bladder problems are of unknown reasons. So they call them idiopathic. And so, what is the reason that this happened? And for men, you might try and treat that enlarged prostate. For women, you might try and give them overactive bladder medications. Those are anticholinergic medications. There's some new beta 3 agonist medications. So
Mhm.
oftentimes it's kind of like lifestyle and exercise and then medications. So that's kind of the standard paradigm.
Okay, so let's start with the exercise and Kegels. I think most of the audience kind of knows this is where you have like kind of tightening in your pelvic region is like a right? Like how would you how would
Yes.
you describe it? Okay.
Yes. Every time I talk about this, it's kind of like a word story. And so one
Yeah.
of the word stories is that if you get into a crowded elevator, and believe me, we're going to get to the food, we're going to get the pharmacology, but if you get into a crowded elevator and you don't want to pass gas, there is a clenching that you do with your pelvic floor muscles that is a contraction, and it's not clenching your buttocks or moving your legs or squeezing your belly, but there are muscles that connect from your pubic bone in front to your tailbone and back, and you're actually, sort of squeezing those and elevating
Mhm.
up that bladder. And so those are the exercises that we do. For women, obviously, obstetric injury can be a really important problem in terms of pelvic floor injury or pelvic floor weakness. Men haven't really thought that much about when and where to use their pelvic floor muscles. And so there's some interesting things about the way that the pelvic floor muscles are connected with the bladder on top. And sometimes you can squeeze those pelvic floor muscles to get the bladder to stop squeezing, which is how we do that in men. Yeah,
That's
we call those
incredible. And so
yeah, we call those urge
how
suppression strategies.
yeah, how frequent of a I mean, if I'm thinking about this as a kind of a workout routine that you could do at your desk, how what have the clinical studies shown in terms of frequency? Like how often does it usually take, for patients to start to see relief from some of the overactive bladder with these exercises?
Yeah, usually about 12
Mhm.
months of workout with your pelvic floor muscles. And so for some people, they can figure out how to do this by reading a pamphlet. Some people can figure out
Mhm.
how to do this after visiting a provider in an exam room. Other people get special pelvic floor rehabilitation services from a physical therapist or a physiotherapist. And
Mhm.
so there are different ways to do this. But usually about 12 weeks, many of these things, including urge associated urinary leakage, can get quite a bit better, probably equal to drugs. It's a little harder to find the providers that do this, but they are out there,
That's incredible. I like it if there's a way we can use, yeah, exercise to, like,
right?
get around things. That's awesome. Okay, so then the next one on your list was caffeine. We're really talking about, caffeine is a plant molecule and it's a diuretic, and we find it in lots of products from coffee to tea to chocolate.
Right.
Yeah, so what can you share with us about that?
Okay. So here's where we're getting into the meat of the story. And now you know that you're on the right podcast. And so, all right. So, one of the things that you talk a lot about is all right. So, if you have this ailment or if you have this difficulty, what is it that you should go out and seek? And what have cultures told us about the plant based treatments in their environment? And so, I'm going to flip that. And we're going to talk about what things should I avoid? Because that's what you just teed up is this conversation about
Mhm.
what should I avoid. And so caffeine is one of those things that's on the list. And so I've been very interested in my treatment strategies versus my partner's treatment strategies. And
Mhm.
whenever you get a group of dedicated folks together and try and figure out, how should we do this? And then you notice that they're doing different things, that makes me very curious. And I know you're a very curious person. So
Yeah.
why should I not spend much time about food avoidance and my colleagues do? And so I went out to public facing websites and identified 5 different reputable messengers of public health messages.
Mhm.
And they went from 10 foods to avoid to 20 foods to avoid.
Okay.
Okay, and so here's kind of the list. Okay, so not surprisingly, coffee, tea, caffeine containing products, including chocolate.
Mhm.
I got some sites that talked about spicy foods.
Huh.
I've gotten some folks that have talked about citrus, and the other one is tomato-based products. And then other people suggested you should avoid dairy, and then you should avoid gluten, and then you should avoid water-containing fruits. And so
Sounds like a very boring
you're yeah,
diet.
I know, I know. So you're getting my gist is that if my goal in life is to help people live fully and live completely in their homes, families, and communities, then giving them a very restricted diet seems very difficult to do. So maybe I thought we could together sort of knock some of these out. So
Okay.
I've done some homework on kind of what we've seen in the patient care literature, like randomized controlled trials, what we've seen in the epidemiology literature, and what I learned from talking to patients one-on-one in clinic. And lots of things about foods and substances and
Yeah.
why this list is generated. Okay, so let's talk caffeine first.
Yeah.
So you talked about naturally found substance, multiple types of plants and ingredient and lots of things. And so I think
Oh,
what I've
there's so
learned,
many more though. I mean, when I think
yeah,
of, like, caffeine and those methylxanthine alkaloids are related to it. So these are, like, chemically similar structures you also find in, like, your 5-hour energy drinks and your Monster beverages. Like, there are a lot of commercial products beyond coffee and green tea or black tea, yerba mate, matcha, hot chocolate. There's, like
it's a lot,
there's a lot. Yeah.
right? And the other thing I've learned from you is tea is not tea.
That's right. Not all tea's caffeinated. The herbal teas that don't contain, like, camellia sinensis are caffeine free, naturally caffeine free.
I don't think that we'll have to drill down as far as understanding whether you use French press for your coffee or whether you use drip coffee, another episode that I enjoyed
Yeah.
very much. But I think as a clinician about the patient and the
Mhm.
dose in terms of understanding the effect. And so It seems in the literature that if you might be a heavy coffee drinker versus a not so heavy coffee drinker, a light coffee drinker, then perhaps there's an effect on frequency of urination and urgency of urination. I think about this in two ways. I think about there's an effect on urine production, the speed at which the urine is produced, and there's also an effect possibly on direct bladder tissue irritation.
Mm.
And so maybe you can shed some light on how much caffeine is in chocolate products, and can we cross off chocolate, because I'd hate to leave chocolate on the forbidden list.
I mean, there's a depending on the product, there's an appreciable level. I mean, one of my naughty nighttime things is if I love to get into some chocolate, and I'm very sensitive to caffeine. I have to
Right,
stop drinking coffee, like, by noon. I can't go
right,
beyond that,
right.
because I will just be wide awake. Like, if I have, even if it's a green tea or something, I can't have it in the afternoon because it just takes everyone metabolizes caffeine and these other alkaloids at different rates. All of our enzymes are a little bit different from person to person. There's variation. So when I have chocolate at night, sometimes I have problems sleeping. So I know there must be, some appreciable levels. And
I I do hit the chocolate cabinet before I go to bed, and
yeah.
so I'm in that team chocolate.
Mhm.
But I would say that I've totally taken myself off of caffeine that comes in sodas and coffees, just because
Yeah.
I get some palpitations, I get some headaches when I stop.
Yeah.
I feel a little nervous and things like that, so I've stopped.
Mhm.
Um, and the smarter websites that I've been to have given you the advice of, well, let's see what this means for you.
Yeah.
Okay, this is a global piece of advice, but let's see what it's been for you. And so if I go to my if I go to the literature and look at this from an epidemiology perspective, it's mixed as to whether or not caffeine will cause you to have overactive bladder, mostly marked by urgency. But I myself get a lot of frequency, like I'll go to the bathroom a lot. If I combine caffeine plus a good water load, then I'm hitting the bathroom
It's
all the
gonna be a
time.
lot. Yeah. Well, I had a question for you too.
Yep.
Isn't when you go to sleep, isn't there some system that kind of switches on that if you're in a deep sleep where you shouldn't feel that urgency to urinate? Like, what how does that system work? Like
Yeah. This was very interesting because my youngest daughter, the youngest of my three daughters, came by with her college friends, and one of them knows about the work that I do in peeing at night. And she said, "Have you solved this peeing at night problem?" And it was really funny because my in-laws were there, and they're like, "I haven't talked to you about this peeing at night problem." So here's the main three things for peeing at night. One is that peeing at night can happen when your bladder has a low volume of voiding, meaning
Mhm.
that instead of peeing out, let's say 200 cc's, you start peeing out 100 cc's. And so you'll be
Okay.
up twice as often. The other is that you can overproduce relative to the total amount of urine that you put out in a 24-hour period. You can overproduce at night relative during the day. So the 20-year-old Ted had no problem sleeping all throughout the night. The 60-year-old Ted has a little bit more trouble. And part
Mhm.
of that is that my body's split of urine during the day and urine during the night has changed. So the 20-year-old Ted might have 80% of my urine during the day and 20% at night. And that 20% of the night is all wrapped up in my bladder and available when I get up in the morning. But now I'm usually up once, sometimes twice a night.
Yeah.
And so that's that we call that nocturnal polyuria. And
Mhm.
then the third most common cause is sleep disturbance, whether that's sleep apnea, a restless leg, or your
Yeah.
daughter's dog sleeping on your feet, or all sorts of other things that might happen that wake you up and you go, gosh, I don't know why I'm up. I must need to go to the bathroom.
Yeah.
And so that's the kind of thing.
As I've gotten older, I need more and more sleep aids, like, I have especially when I'm traveling. When I'm at home, I have one of those weighted blankets. I'm, like,
Right?
trapped under there so I can't
Right?
move, and it kind of soothes me. Getting your night's sleep has become more and more precious to me. Um,
Right?
yeah,
Exactly.
yeah, yeah.
So you and I might agree that caffeine's probably important. It's
Mhm.
probably individualistic, and the chocolate has some caffeine depending on the type. And so, okay,
Yeah.
try to do less, and we'll see what happens with your bladder problems.
Yeah.
I found in my 20 years that I've had one patient that we modified just his caffeine intake, and all of his problems went away.
Oh,
Other times,
wow.
I think just one. And so other times you have to, work on a couple of different things at the same time.
Yeah.
Right. So that
Kegels
knocks
plus
out,
a cup of coffee.
yeah. So that knocks out caffeine and tea and
Yeah.
colas and things like that.
What
So
about alcohol? I don't know if that was on your
yes,
list. Does alcohol have an
yeah.
effect on the bladder? Mhm.
Yes, alcohol has an effect probably on urine production in that it causes your kidneys to produce a more voluminous, dilute urine, and it interferes with the renal concentrating mechanism. So, yeah. So, and then that gets into the timing. And so, probably a
Mhm.
lot of nightcaps, probably not so good. But yeah, alcohol does have an effect as well. And that combination of an alcohol plus a water load will end up having you
Can
pee
really
a
do
lot
that.
as well.
Yeah. Well, and there's this balance, right? If you're having
Right.
alcohol, you're told to drink, more water because it's very dehydrating.
True.
Um, Interesting. Okay, so maybe trim back on the coffee and the alcohol. But let's get into some of these other foods. I mean, I was surprised to hear about, well, no, let's start with capsaicin and spicy foods, because that's
Yes.
interesting. Or is it just for, like, chili peppers or also black pepper? Like, what's the literature say?
Yeah, the literature needs a consultation with Cassandra Quave because it's so vague that that's why
Spicy.
I was sent here by the field of medicine to come and get a
Okay.
consultation from you. And so why don't you tell me what means spicy and I can maybe relate it to what they're perhaps talking about.
That's incredible. We need what we need to do is I need to call up, David Julius, he got the Nobel on, capsaicin and pain receptors. He actually did the show years ago. He was one of our early guests before the Nobel. And, that we have these pain receptors in more places than our
Right.
tongues, which is interesting. So
Right.
I wonder, like, are there pain receptors in the bladder? And if so, well, you have piperine from black pepper, which can act on those, was it the tryptophan-1 receptors and capsaicin, the tryptophan-1s? I don't know. So maybe a spicy bladder is not good. I don't know though.
Yeah,
Yeah.
and you wonder how, I think that it's a lot easier to connect food avoidance to improved bowel symptoms. It's a
Mm.
little bit harder for me to get to the bladder sometimes
Yeah.
because obviously you've got to get everything through a filtration system, and obviously small molecules go through.
Mhm.
And so you have to figure out, all right, so what are the proportions and concentrations there? And so maybe just some thoughts about bladder physiology. There are probably some local effect on the bladder lining of some of these chemicals, and there are probably some systemic wide effects of some of these chemicals. And so I can't really tease apart which one's which. But I'd hate to just recommend a bland diet for everybody with overactive bladder. I mean, it's
Yeah.
perhaps as many as 50% of older women and 25% of older men that have overactive bladder symptoms. So that seems
That
very
seems
boring.
Yeah, it does seem boring, and well, if you think about it from a epidemiologic perspective, I mean, there are certain cuisines
Yes,
where the whole population eats intensely spicy food.
right.
Thinking, yeah, certain, foods in Central America, but also in Asia, India. Um, so I would expect you'd see population-wide effects with, like, lots of people with overactive bladder, like, or more so in those populations, and does that seem to be the case, or has the literature not really taken that approach to looking at this yet?
I think what you're saying is absolutely spot on, and the sort of the seminal effort to sort of demonstrate that is looking at Japanese persons living in Japan and Japanese people living in Hawaii and Japanese people
Mm,
living in the United States, and
yeah.
you can begin to see how diet changes and the incidence of colon cancer changes, and
Mhm.
that's a great example of kind of cultural epidemiology to kind of understand the interaction between people and their foods and what
Yeah.
happens. And so the other thing that's kind of intersecting here is that there are definitely some strong effects on body mass index on bladder symptoms, particularly with
Hmm,
regards to um, stress related coughing, laughing, sneezing leakage of urine,
okay.
but not so much with regards to urgency incontinence. So I'm going to put that down on my list to sort of find out, all right, so let's find some spicy food cultures and figure out what their overactive bladder rate is and figure out what it is here. Because I think that it'd be hard to randomize somebody to a bland diet for a year to figure out what that does. That seems
Yeah.
highly unlikely.
I mean, unless you could, like, pull together a group of volunteers to live in different countries for a while and track it, I mean.
There we go. Sign me up. I'm ready for that.
Yeah.
So when you think about okay, so one of the things that's great about you and your work is you talk about this notion of, all right, so we're going to recommend a Mediterranean diet. You and I have talked about this before, and so all
Mhm.
right, so what does your Mediterranean diet look like in Greece, and what does your Mediterranean diet look like in Atlanta? I mean, those are two different things in terms of the types of access that you have, but there are probably some principles that are the same.
Mhm. Yeah, no, I 100% agree. It's hard to nail down what this diet is, and it's also access, yeah, to ingredients, and I hate to break the news to the listeners, but the Mediterranean diet, you can't just drink red wine and say you're following the Mediterranean diet. There's there's a lot of, but it's not also just a diet. I think that's the key. It's not about the food. There's lower meat, more green bitter vegetables, which is the true Mediterranean diet. You see this in Greece, you see this in Italy. Um, that doesn't always cross over to our American idea of the
Right.
Mediterranean diet. I mean, if for any of the listeners that have had, for example, dandelion greens, that's closer to what they're eating when it comes to wild spring greens. These are very bitter, and savored because of that. And then fish, of course. Um, but there are different ways. Their breads, their consumption of carbohydrates is different than ours. I can tell you a story of one time I had some colleagues from the Balkans come to visit in Atlanta to do a research stay, and you know, first day they arrived, I took them to the grocery store and I'm showing them around the grocery store and I'm like, "And here's the bread." And they said, "No, where's the bread?" I'm like, "Here it is." And they said, "No, where's the bread? That's not bread." It's like, all the like bread is not supposed to stay on the shelf for
Right.
a very, this is the bread you get every day. Like they really panicked. I was like, and it's hard to understand that if you've not been exposed to real what it's like to have real bread without, that's made with this much more complex durum, whole wheat, reared in a different way, that they're cultivated in different ways than we have access to here. And yeah, there's a lot of factors. You're right. But also the exercise. So when you
So
mentioned body mass index, are we
yeah,
talking about the heavier you are if you have, for example, metabolic syndrome, if you are not in great physical health, are you more likely to have these problems as well?
yes, you are, but it's interesting because some bladder symptoms travel in one direction and some bladder symptoms
Mhm,
travel in another direction. I think that if we just framed it as an overall bladder health, which I think is a good way to talk about it today,
mhm,
uh, you could basically say that lower body mass index and kind of the normal weight or overweight is much better than the obese or morbidly obese in terms of your bladder symptoms. And
mhm.
when you get surgical correction or intensive dietary correction and lowering weight of about 5 to 7%, your bladder symptoms get better. And
Wow,
so, yes, so this is a pretty well established linkage,
interesting.
but
So
not so much about spicy foods. That seems a little
yeah,
big.
I don't know if I'm buying this spicy, but I'm
So, if you were thinking about spicy and you were thinking about, okay, so let's go back to the example of there might be certain spicy foods that individually are a trigger for you. And so,
mhm.
how do you think about different types of spicy? And you began to say that earlier.
I mean, I think about spice in a like a weirdo because 'cause I'm like, like a robot. Here's the chemical names of the
But
of
that's
the
okay.
of the molecules that hit our pain receptors that we interpret as being spicy. So, I mean, I'm thinking old world and new world plants. So, that's another way to think about it. So, I'm thinking chili peppers and all the many different varieties of capsicum annuum, whether it is a jalapeno or a cayenne or a serrano or a habanero. All these things go back to the same kind of genetically related, but somewhat different based on how they've been bred by farmers, and local cultivators over years. Then, on the other hand, there's two other Asian spices I think of. That's black pepper, Piper nigrum, um, which is a fascinating plant in its own right because piperine also potentiates or improves the bioavailability of other drugs, including curcumins, of turmeric. And then there's Szechuan pepper, which, believe it or not, is in the citrus family. And I'm not sure which molecule. I'm like, now I'm ashamedly, I'm like, which is that is gonna drive me crazy. Which molecule is found in Szechuan? But that's in a completely different family. It's in the citrus family. So you have citrus family, the black pepper family, and then we have the nightshade family. So from a evolutionary perspective on plants, very different clades and very different molecules
Right.
in each of these that elicit, they act on those pain receptors, which we interpret through our sensory experience as being delightfully painful.
Right. Well, I'm going to get my Cox postulates, KOCH
Mhm,
postulates wrong, but basically, if you have a symptom, you take away the offending agent, and then the symptom goes away, and then you introduce the offending agent again, and the symptom comes back. That's kind of like, okay, so maybe this is something that I should avoid. And you're coaching us on thinking about, all right, so spicy is not just spicy, and let's think about what these actually are. There may be one type of food that you need to avoid because that in particular is a trigger for you, but that
mhm.
doesn't mean that you should throw out all four of those families of
Yeah.
spiciness.
No, that's a good point. I mean, there's also a lot that we don't know about food intolerances, food allergies. Um, It's fascinating, like, I have a food intolerance to bell peppers, the big sweet bells. They make me, I mean, it's like a scene from The Exorcist, it's awful, like, I vomit. It's, like, really bad. But I can eat jalapenos, I can eat serranos, and they're all, like, the same species name
Right.
even. It's just that they have been bred and they have some slightly different chemistry. Is that one chemical found in the bells, in the skin of the bells, that makes me very ill, and this is not that uncommon of a food intolerance. I've met other people that have the same. They either get severe indigestion or they vomit. And so there's a lot for us still to understand about food chemistry and how we as individuals respond to it, right?
And I think I'll take that message home to my wife Susan because she really, if there's a bell pepper, if that one, and so her kind of thinking about this is that if it's a pepper and it looks green, then that's kind of her signal to avoid it. And maybe there's some subtleties about, hey, maybe it's just this one.
Yeah, I think it's that one, for me, at least, it's that one variety, and color doesn't matter in that context, it's whether it's a green, red, orange bell pepper, and I'm so sensitive to it, I
Right.
can smell it, like,
Right.
I mean, it's like I have these crazy, spidey senses for, "Is there bell pepper in this dish?" And I
Right.
know not to mess with it because I've had such bad reactions before. I did wanna go back to one thing about BMI as a bigger
Yeah.
question for where medicine is going right now with these GLP-1 inhibitors.
Right.
And for the audience, GLP-1 inhibitors, that's the key kind of ingredient, semaglutide, the ingredients that you're finding in Wegovy, in, Ozempic, in these, now we have oral and injectable formulations, and these could or seem to be helping patients achieve, weight loss. It's approved for diabetics now, but could you foresee any way that these might be used down the road for patients that have a high BMI and suffer from these, for symptom relief?
I do think so. And because we're talking about overactive bladder, we might say that the mechanism for some of these things might be related to body mass and that these
Mhm,
medications might be helpful. So here's what makes people in my field of geriatrics nervous. And it's two things. One is that weight loss in older adults, and by that I might mean myself at 60 or folks
mhm.
65, 70. There's some really disturbing observational data about weight loss in older age that is probably linked to other reasons why people lose weight as they age that are worrisome because of the underlying mechanism by which they're worrying. So there's one level of caution in my group of patients in that weight loss in older adults might not be the same as weight loss in 30s and 40-year-olds. So that's one
Okay.
caution. The other caution that we have is kind of trying to understand what these really novel and helpful medications do in terms of how much of that weight loss is muscle weight loss.
Mhm.
And so, what happens to your functional ability to stand up from a chair or to walk
Yes.
or to not fall and those sort of things. And so, that's kind of what's got us in well, let's see how this goes sort of framework for
Yeah.
my people who are 60, 70, 80, 90.
That makes sense. I mean, I think in this group too, I mean, thinking about products that target this age group, I'm thinking of Ensure and products to help them get enough nutrition,
Right.
keep weight on. So,
Right.
yeah, I hadn't yeah, that's an interesting distinction between
Yeah.
weight and age.
But I do think that you're on the right track in terms of thinking about, okay, so let's think about other ways to help solve this old problem.
Yeah.
Let me let me try one more on you in terms of
Mhm.
this 20 list of 20 foods that you can't have, and we'll throw out and not discuss the gluten and the dairy and
Yeah.
other things that I can't describe, that I can't really talk about. And so we talked about allergies and we talked about sensitivities, and I guess you would have to put this in the sensitivity category, and so
Mhm.
that is citrus. And
Okay.
so, walk me through citrus and tomatoes. Maybe we'll tackle them both at the same time.
Oh, wow.
Citrus and tomatoes. Why? What do you think is common there? And if you just want to forego all citrus, you need some vitamin C from somewhere.
Yeah, I mean, well, they're 2 different plant families again.
Right.
They have in common acidity. I don't know if acidity of pH of your foods has any role in or if
If you take out strips of bladder and throw some potassium hydroxide
Mhm.
on them, you get some weird muscle contractions. And some people think that your overactive bladder with urgency is tight electrical junctions and chemical irritation. So yeah, so maybe there's something there, but I'm trying to get that as a concentration in your urine that would make a
Yeah,
difference.
how would
So
you achieve that? If that's the
yeah,
case, then you would need to think about vinegar as well, like any kind of acidic food.
vinegar's
Um,
on one of the lists, but not all of the
some
lists.
of the others,
Vinegars.
yeah.
Yeah, these lists are interesting because they're all revised and posted online in 2023 and 2024. They're none of them reference kind of the Sentinel sub uh, topics, and they all reference each other as kind of where did we get this
That's where you get
information?
it's like a circle of
It is like a circle
Yeah,
of either good advice or bad advice, and so
yeah.
I want to be cautious about that.
Yeah, I mean, it's interesting, in citrus, you can have in dermatology, citrus can be tricky because you can have these very photoactive molecules, like, the classic stories of getting contact dermatitis after squeezing limes at the beach and you're in the sun and you can get these really bad skin reactions, but that's like, you're not gonna have that in the bladder. Um, when I think about tomatoes, I don't know, the most I think about tomatoes is really how you get some of the good compounds into the body, like lycopene, and how do you how do you have better absorption of those? I don't know as much about the irritant properties of tomatoes,
But you're
but they
putting
are not they're related to peppers. I mean, maybe there's something in common.
yeah,
I don't know with
you're pointing out something really important. So once you eliminate these from all of your diet, and
Mhm.
then how are you supposed to get the needed substances that these fruits
Yeah,
and groups get? And
they're
so I've,
very
I
important
always
resources.
yeah, I've always thought about this as kind of like, okay, so maybe this is bad advice that's bothersome, but there's actually some negative effects. It's like, where would you get the needed chemicals that your body needs in order to
Yeah.
survive?
Well, and lycopene, there are lots of water-soluble antioxidants we can get in the diet. Any of your dark berries, your, leafy greens, a lot of these are water-soluble. There are 2 key ones, though, to get in the diet that are fat-soluble, well, out of foods. You also have vitamin E, tocopherol, and those analogs. But, um, when it comes to, like, turmeric and when it comes to tomatoes, the best way to actually uptake those is through cooking them with some sort of fat, whether it's animal or plant-based fats. There are many fewer fat-soluble antioxidant opportunities in the diet, and tomato is definitely one of them. So if you're, and tomato paste is one of the best sources of it. So cooking your tomato paste in that olive oil is actually you're getting a really nice dose of and those antioxidants, of course, they reach different parts of your body, which is important to your health, right? The water soluble ones go to different places than the fat soluble ones do. Um, yeah, so I think you're right to urge caution that we don't get on this train of so much elimination,
Right.
um, especially since it's not really evidence based. We need better
Yeah.
controlled trials. What's your dream trial? Like, how would you
Whew.
design something to look at
Yeah.
it?
So I think about this a lot in folks who are aging, and you think about multifactorial problems
Mhm.
and multi-component interventions. And so there's this new type of clinical trial that are called smart trial designs. And basically you take the most logical suspect that could be causing problems. And if I had the money to do such a trial, I would throw out alcohol and caffeine. I would say, okay, there's some reasonable,
Yeah.
biologically plausible mechanisms by which that might cause problems. And so let's tackle these things like citrus and spicy foods that I think would be really bothersome. And so you would probably introduce thoughtfully one or more of said compounds to figure out what it did to your symptoms. And so one of the cautions with overactive bladder is that people who live with overactive bladder, their symptoms may be bad one day, good the next day,
Mm.
and no one's really sure why. And so you try and control for as much of that as possible. So that's probably what I do. And the smart trial design is once you get rid of the first question and look, hey,
Yeah.
citrus didn't have anything to do with this, and then you'd go on to tomatoes. And then if tomatoes didn't have anything to do with it, and then you would go on. And you'd have to either eliminate these or supplement them. Perhaps it would be less scary to supplement, like, hey, we're going to give you a really spicy diet for about 5 weeks. It'll be really entertaining, and we'll see
Yeah.
what happens to your bladder symptoms. I'd like that rather than depriving people.
Yeah,
So
I think that's a better way too. Yeah, and would they just keep, like, logs of the like, how do you track this from the do they just keep a record of when they urinate and, like, or how
here,
frequently?
yeah, here's a great thing, and you probably think about this anytime you start recording or observing something. This it changes the nature of what happens, and so
Mhm.
that Hawthorne effect of now that we're recording and paying attention to it, it's actually different than it was before. And in bladder symptoms, when we've done clinical trials and looked at things that we know to be very active, we found that the process of keeping a bladder diary ends up having you get better from all of your bothersome
Amazing.
symptoms. And so a little bit hard to do. I think that I'd rather go live in countries with spicy foods and do some epidemiologic work to figure out if it's different that way.
I love that. That's a great idea. Well, I think we're just about out of time. Any last thoughts, takeaways?
I know that your listeners are super smart, and I welcome thoughts about this topic. Again, just a caution: we're talking about overactive bladder, not a pathologically defined symptom like interstitial cystitis, which we didn't talk about at all, but is
Mhm.
probably very different from the routine run-of-the-mill overactive bladder. But I welcome help on these. These are real problems, and I appreciate getting a chance to talk to you, one of my esteemed scientific colleagues who thinks about things a lot. And so I appreciated having the chance to come on and talk about it.
Awesome. No, this has been a pleasure. I learned a lot today, and it's always fun to chat with you. Thanks so much.
Thanks,
We
Mike.
had, Dr. Ted Johnson on the line. Thank you. All
Thanks so
right.
much.
You've been listening to Foodie Pharmacology, the science podcast for the food curious. I want to give a shout out of thanks to our producers, to Rob Cohen and Christine Roth of Co-Conspiracy Entertainment. And I also want to remind all of you listeners that we have the podcast available both in video and audio format. So if you're tuning in through one of your favorite podcast streaming platforms, that's awesome. Stick with it. If you're looking for more of an interactive, flair, a little bit of video, you can head over to the Teach Ethnobotany YouTube channel. You can also find that through our main website at foodiepharmacology.com. That's Foodie pharmacology.com.